Definitely, yeah. So we have had quite a few exciting trials in the newly diagnosed space in multiple myeloma in the last couple of years, and I would like to highlight three trials which I think are the most important, and they were all kind of updated in the last year or so. So one is the Griffin trial. So as you know, in multiple myeloma, especially newly diagnosed transplant eligible myeloma, the default standard for induction regimen is a 3-drug regimen with proteasome inhibitor, an immunomodulatory drug, and steroids, mainly VRD. That's the one that we have been using. And this trial asked the question whether adding a fourth drug, that is an anti-CD38 monoclonal antibody, daratumumab, will be able to improve outcomes or not. So this trial tested Dara-VRD versus VRD in patients, all of whom went to upfront transplant, followed by consolidation and then maintenance. Now, one important thing to note here is that there was no second randomization at maintenance. So patients who were in the Dara-VRD arm, they got Dara in the maintenance, and those who were in the RVD arm, they did not get Dara in the maintenance, but there was no second randomization at the maintenance stage. So having said that, this was a phase 2 randomized trial, and it was a positive trial showing that at the end of consolidation, patients who were in the Dara-VRD arm, they had a higher incidence of stringent CR rate compared to those who were in the RVD arm. The follow-up is still relatively short, to know whether there is a PFS benefit, but most likely there will be. So this is one of the most exciting trials that, in the last year or so, that kind of have changed some of our practice including a quadruplet for upfront induction regimen, especially in transplant-eligible patients. The second trial, which I'm the most excited about, is the Cassiopeia trial. This was a similar trial, testing Dara-VTD versus VTD head-to-head. Now you will note that thalidomide is not, used in the US a lot anymore. We primarily use Revlimid. However, I think this is a very important trial because of a few reasons. So first of all, it was a large phase 3 trial, which showed that, again, the addition of Dara to VTD, it improved overall outcomes, including stringent CR rate, MRD negativity rate, as well as progression-free survival. And most importantly, there was a early signal for overall survival benefit in the Dara-VTD arm. So I think, when we interpret the results of the Griffin trial, we have to interpret that in the context of the Cassiopeia trial, which has already been, published, and there is already a PFS and the overall survival benefit as well in the Dara-VTD arm. Now, one important thing that I would like to highlight in the Cassiopeia trial is that if you look at the post-consolidation MRD negativity rate, there is increased chances of getting MRD negativity in the Dara-VTD arm that was true both in standard risk and high risk patients. So this trial did show that addition of Dara does lead to increased MRD negativity in high risk patients, and that was statistically significant. So I think that's very important data, at least up until we have data on trial level surrogacy of MRD in patients with myeloma. I think this is the best data we have, one of the best data that we have on achieving MRD negativity with a quadruplet regimen in high risk multiple myeloma. And hopefully that will translate into improved PFS and OS for the high risk subset in future. And the third trial is the Forte trial, which was updated again in ASH of this year, last month, by Dr. Guy and colleagues from Italy. And in Forte trial, there were 3 arms. 2 arms basically had KRD with or without ASCT transplant, and the third arm had KCD with ASCT. So I think this trial is important for a few reasons. We don't routinely use KRD induction in the US. However, I think I learned 3 important things from this trial. The first thing is that outcomes with KRD and upfront transplant can be excellent when it is used in the appropriate patient population, that is the fit transplant eligible patient population. And you will see that in this trial, the 3-year PFS in high risk patients with this combination, that is KRD followed by transplant, was 70%, which is unprecedented PFS in this high-risk population. The second thing that I learned is that sustained MRD negativity is the key, that MRD at one time point can sometimes deceive us, as we saw early in this trial, that patients who underwent transplant versus those who did not undergo transplant in the KRD arms had a similar MRD negativity early on, but those who underwent transplant, they had a higher rate of achieving a sustained MRD negativity, and subsequently that translated to an improved progression-free survival. So I think sustained MRD negativity is the key. And finally, the third thing that I learned from this trial is that addition of a proteasome inhibitor and immunomodulatory drug in maintenance therapy, it works. Most of us have been doing it in high-risk patients based on the Emory data, which showed excellent PFS, especially in high-risk patients. However, this is, I think, to my knowledge, the first randomized trial showing that addition of a PI to an IMiD versus an IMiD alone leads to an improved PFS in the maintenance stage. And this was true even for high-risk patients. So yeah, I think these are some of the exciting trials that I really have been interested in the last year or so.